A very good morning to everybody. At the very offset, I'd like to thank the organizers of this IPedia workshop for inviting me to deliberate on a topic which is quite close to my heart. And I'm also thankful for them for giving me a topic for which not much preparation is required. Because when we talk to pediatricians about failure to thrive and not growing, often what I see is that half of them are asleep by the time I start talking, and the remaining half become asleep by the time first light goes off. So most of you will be thinking that why are we having a talk on a topic like toddler falling off the curve when we have more interesting and more pressing situations like celiac disease, pediatric pulmonology, hyperbilirubinemia, and those topics are going to talk. So often you will be asking is why do we need to talk about a condition which is extremely common, easy to assess, and easy to treat. So why are we wasting half an hour on this topic? I'll put forward two cases which will show why there's a need to discuss about failure to thrive, and particularly in this age group which forms the period of one of the most rapid growths and when the whole tracking of growth happens by this time. This was this 15-month-old girl who was born with a weight of 4.1 kilograms, and the pediatricians were very carefully monitoring the growth cycle, and what we were finding was that she was actually dropping 4 percentile lines, and they became really concerned. Initial workup was done which showed a normal complete blood count, SGPT, creatinine and TSH. Blood gas, IGF BP3 to look for growth hormone axis was normal, and a TTG level was done which showed a level of 32. No biopsy was done and the child was started on gluten-free diet. The parents were extremely confused, and so were we when we evaluated the growth chart, and I will show you on the growth chart as to how this erroneous diagnosis of celiac disease was made in this child, causing a lot of trouble for the entire family. And as Dr. Neelam will be talking subsequently, there has been a whole cycle of situation in which once we were underdiagnosing celiac disease, there now seems to be a overzealous enthusiasm in picking up cases when it is not existent in those situations. The second case was even more tragic, a 4-year-old boy with failure to thrive who had been to multiple doctors with growth failure. X-ray showed clear-cut rickets. Received tons of vitamin D. So every time they would go to an orthopedician, they would write an injectable or an oral vitamin D. There was no significant improvement, yet no workup was done. And when the child came to us, it looked pretty clear that the child actually had polyuria, and workup showed metabolic acidosis and nephrocalcinosis. So when we're talking about growth failure, particularly in toddlers, it's like walking on a tightrope. It is a situation where we have to balance the fact that 2/3 of them would largely be related to physiological or nutritional factors which do not require extensive investigation. On the other hand, approximately 1/3 would have a serious underlying pathology like celiac disease, renal tubular acidosis, and even craniopharyngioma, which should not be missed. So the whole crux of evaluating a short toddler or a short child lies in balancing, on one hand, not doing excessive investigations for somebody with a physiological cause, while using clinical clues to identify pathological cause and do guided investigations. And that's what we will aim to do over the next 15 minutes or so to evaluate and develop a comprehensive assessment system in this regards. So the three key issues that we like to focus is the why, when, and how of growth failure. And of course, the most important question is what's the cause of growth failure in toddlers? So if you look from that perspective, growth failure can classically be classified into either a physiological form, which most commonly would represent a familial short stature at this stage, or a pathological cause. Within the pathological cause, the problem could lie either in the core growth plate, that's why the growth is not happening, like dysplasia, small for gestational age, or genetic causes, or more commonly in the environment is responsible. The environmental causes can then be classified widely into either ones which are related to nutrition in the form of malnutrition, malabsorption, chronic systemic diseases in which we like to fit celiac disease, tuberculosis, renal tubular acidosis, cystic fibrosis in that regards, and endocrine causes like hypothyroidism, growth hormone deficiency, and Turner syndrome. So the whole aim of evaluation of a child with growth failure would include first to confirm the diagnosis, then to differentiate between whether it's a normal cause or a disease, and finally whether it is a nutritional or an endocrine cause. And these three questions, if answered, would really help us in evaluating a child in this regard. So now the second question which obviously comes to our mind is, does this child really require evaluation for growth failure? And for that, we need to measure the child and plot on the chart. I wouldn't go into the controversies about which chart to available. Now we have new IAP guidelines which are talking about the IAP growth charts. But what I would like to just suffice to say is that use any growth chart that you're comfortable with, provided you correct it for the mid-parental expectation, which we'll discuss in some time. So I'll just put forward a few cases and ask whether you think this child requires evaluation. So this is a 3.5 years old child. Do you think this child requires evaluation as far as growth is concerned? And for all this, we assume that the mid-parental height is at the 50th percentile. I think there's no doubt that somebody who is very short, height is below the first centile or -2 standard deviation score, requires evaluation. What about this child? The height is just below the third centile. You think the child requires evaluation? Maybe we can follow up. So on follow-up, what we see, the child is actually drifting away, and somebody who is short and not growing, that's height is between first to third centile, and growth velocity is less than 25th centile, requires evaluation. Does anyone of you think that this child who is lying between 10th to 25th percentile requires evaluation? No, this is actually we had the opportunity of having the information about the past growth, and mother was really concerned about that this child is not growing at all. And when we actually followed that for the last 2 years, he had a flat growth chart and he had crossed more than 2 percentile lines. And crossing more than 2 percentile lines between the age of 2 years and puberty is highly pathological. And this would indicate that we are dealing with something which could be an acquired cause of growth failure, which could be as sinister as a craniopharyngioma or as simple as hypothyroidism. So somebody who is very short or not growing at all requires evaluation. The next issue which comes to our mind is how to evaluate and what things to look into. So first step is obviously to compare between whether it's a pathological cause or a physiological cause. And what would be the most important clue to diagnosis in this regards? In other words, what's the most important investigation in a child who presents to us with growth failure? And in fact is the growth chart. And the three things that we have to look on in a growth chart are: what's the current height and weight percentile, which tells us information about the absolute status; what's the parental expectation, which gives us information about the familial effect; and finally, what is the height and weight age, which is extremely important, and I'll come back to it in the form of nutritional effect. Now, what really is height age? Height age is the age at which the current height becomes equivalent to 50th percentile. And same is for weight age. In conditions when we talk about evaluation of growth failure, it's quite easy to compare physiological to pathological. And when you have evident dysplasia, it's quite evident. The most common confusion is comparing between nutritional cause and endocrine cause. And the set of investigations are entirely different. So somebody has a nutritional cause, you will be focusing on a CBC, more of a MON2s or a ESR or a chest X-ray or a TTG, blood gas. But on the other hand, you will be doing IGF1, IGF-BP3, growth hormone stimulation test, karyotype. So distinguishing between these two causes is a very important goal. And the most important clinical clue to do that is to look at the height and weight age. In nutritional causes of growth retardation, it is the weight which is primarily affected and height is secondarily affected. So they will have a situation wherein the weight age would be much lower compared to the height age, while in endocrine causes, height and weight age would be similar, or in fact the height age will be more affected. And this is one of the most important messages which I like to probably go through this presentation, and will really help in terms of evaluation. So now we will not waste any further time. We have this 4-year-old girl whose height is 92 centimeters and weight is 10 kgs. So this is how we plot. We said the second step was to really look at the mid-parental expectation. So father is 164 and mother is 151, and that gives us a mid-parental height of 151 centimeters. There's always a range to that, so we subtract 6 centimeters from that and we add 6 centimeters to that, and then we try to draw a parallel line from the lower limit and the upper limit, and this gives us the growth chart for this particular family. Now the final step, as I said, is to look at the height age and weight age. For that, we draw a line from the current height which goes up to the 50th percentile on the growth curve, and then draw a line perpendicular to that. So this girl at the age of 4 years has a height age of approximately 2 years and 9 months, and same is for the weight age, which again comes out to be quite similar. So having looked at this growth chart, what do you think is the most likely diagnosis in this child? Is this familial short stature? Is it celiac disease? Is it growth hormone deficiency or hypothyroidism? The answer is very clear. It's familial short stature. Now coming on back to the original case that we were discussing about, this 15-month-old girl with infant of diabetic mother, which we brought retrospectively when we asked the question as to why was this child so large at age. This was the height and weight, and the child was actually tracking till around 15 months of age, and when the pediatrician became really confused and did a TTG and advised gluten-free diet. Now at that point, when we really assessed, we found that this child's mother was short, and so we really reassured and we just followed up the child, and when on follow-up we found the child kept on growing down to the mother's height. So what do you think is the most likely diagnosis? Is it renal tubular acidosis? Is it celiac disease as suspected by the pediatrician? Does this represent a cash down growth, or this could be hypothyroidism? This is clearly a cash down growth. So size at birth is determined by environmental factors, while size at final height is determined by genetic factors. Now the next important step to look at in this regards is the bone age assessment, and anybody who has ordered a bone age would really be disappointed by the results that the radiologists give. We wouldn't go into detail as to what really is, but let's highlight a few points. So what do you think is the most important part to look at in a bone age X-ray? And that's the least important. The most important part actually are the distal bones and the smaller bones, which are most important. What we need to remember is that the maturation starts from a proximal to a distal fashion, while fusion is in the reverse direction from the distal to proximal direction. And except for early infancy, maybe till 2 years of age, where we'll have some role of carpal bones, predominantly as we become older, the bigger bones will become more important. The smaller bones will become more important, will give us more information. So now we have worked out that this child actually has a pathological cause of growth failure. The next issue is how do we work up for that pathology. And the three things which we'll need to really look into are the pointers to diagnosis, looking at whether it is nutritional or endocrine, and then go forward as far as investigations are planned. Now, often we'll have clinical clues either on history and examination that are extremely important to identify. And they should include things like polyuria, which will indicate a possibility of renal tubular acidosis or diabetes insipidus, anemia, which will indicate renal failure or celiac disease, disproportionate short stature will obviously point towards a dysplasia, and lymphedema, particularly in the infantile period, will indicate a possibility of Turner syndrome. So now this is a 6-year-old girl with growth failure, and we found that this child actually has this sign on hands, and this is her X-ray from infantile. The height is minus 2.5 standard deviation score. What do you think is the most likely diagnosis? Is it renal tubular acidosis, Turner syndrome, growth hormone deficiency, or pseudo-hyperparathyroidism? So what is this sign we're looking at on the left hand side? This is the brachymetacarpia. So if you have any girl who comes to you with growth failure, ask her to clench your fist, not to hit but to see if there is a depression between the fourth metacarpal, and this is lymphedema. So if you have any of these, you can diagnose this child as Turner syndrome. Turner syndrome is a very important cause of growth failure in girls, and it has much wider implications beyond just as far as growth is concerned. Now we have another 5-year-old girl whose height is here and weight is here, and the mid-parental expectation is at 150 centimeters. So this is the height age for the child is around 3 years, and weight is around 2 years, and this is the mid-parental expectation at around the 5th percentile. So what do you think is the most likely diagnosis in this girl? Is it familial short stature? Is it celiac disease, growth hormone deficiency, or hypothyroidism? Exactly. So if you look at this child, what we see clearly is that the weight is primarily affected, and it is much less as compared to the height. So it has to be a nutritional cause of growth retardation that excludes GHD and hypothyroidism. She is shorter for the family, so it cannot really be familial short stature in the truest sense because the weight is also very low. So in that perspective, the only logical diagnosis would be celiac disease. What about this 4-year-old boy, pretty short, has hypokalemia, and somebody did an ultrasound which showed this picture. So what's the diagnosis? Is it familial short stature, celiac disease, growth hormone deficiency, or renal tubular acidosis? Exactly. So renal tubular acidosis is a very common cause of which is missed as far as growth failure is concerned, should be considered in any child who has rickets, polyuria, hypokalemia, neck flop, along with growth failure. Now we have another situation of a 2-year-old boy whose height and weight were both compromised, complained of recurrent fever. All the screening workup were normal. They had worked up for all infections. Everything was there. And somebody thought that we'll do electrolytes, which showed a sodium of 168, potassium was 3.6, and a low urine osmolality. So you have a child who has recurrent fever and dehydration, hypernatremia, and has low urinary osmolality. What do you next? You look at the response to vasopressin, which was not there, and diagnosis nephrogenic diabetes insipidus. And I'll really like to put forward that this is a very common clinical presentation of children presenting around 6 months to 1 year of age. They are always dehydrated, admitted often with gastrointestinal symptoms, not growing at all, fever, because they don't have an intact thirst mechanism. And if you do electrolytes, you'll really be able to identify these children in this regards. This is a nephrogenic DI. If you have a child like this walking to your clinic, I don't think there's any confusion of hypothyroidism, but often children with growth failure may have no clinical features of hypothyroidism, so a FT4 and a TSH should be done in all children. We have this 5-year-old boy, height is here, weight is here. If you look at the height age is 2 years and weight age is 4 years, parental expectation is between the 10th to 25th percentile, and this is the child. What do you think is the most likely diagnosis? Is it renal tubular acidosis, celiac disease, growth hormone deficiency, or systemic infection? What is very evident on this evaluation is that this child actually has a very retarded height age compared to the weight age. Clinically also looks very plump, has micropenis, undescended testes, doll faces, and this is a classical case of growth hormone deficiency. Just a word regarding growth hormone IGF-1 axis evaluation. If there is one message, is that it should be done only after excluding all other causes of growth failure. There is no role of basal growth hormone, which is a waste of money because it's a pulsatile secretion. IGF-1, particularly during infancy and in a setting of malnutrition, has limited role, and it is the growth hormone stimulation test which is the key as far as evaluation and management is concerned. So just to summarize the whole presentation, first is to look at the height. If the height is more than 3rd centile, nothing is to be done. If it's 1st to 3rd centile, follow up the child. If it's less than 1st centile, look at things like dysmorphism and screening tests. If they are positive, you have your diagnosis. If they are negative, look at the weight age. If the weight age is predominantly affected, think of a nutritional cause, things like nutrition, infection, celiac disease, and blood gas. If it's more than height age, look at thyroid, karyotype, and a growth hormone study. So just the key take-home messages would include that growth charts are essential for evaluation. Weight is the most important part to look at and do a stepwise evaluation. Just about a key resources which are available include the Growth India, which is Growth and Obesity Workforce, has brought out pediatric endocrinology protocols, which will be quite helpful about entire parts. And all the presentations are available over my website, which can be accessed. We'll also like to invite you to join Pediatric Endocrinology India at Facebook, where all the presentations are loaded and there are a lot of interactive forum as far as pediatric endocrinology cases are concerned. Once again, I have to thank all of you for patience.